get ready for our last panel of the afternoon coming up here in just a few minutes, future state of interoperability. So please stand by. And now a message from our sponsor, NextGen.
Healthcare providers count on having patient data at their fingertips. They don't think about how they get it, they expect it. Behind every doctor using data at the point of care exists a complex network of interoperable systems talking to each other. When a healthcare organization operates its own interoperability network, it has to wrestle with costs associated with on-premise infrastructure, licensing multiple engines, disaster recovery, regulatory compliance, and integration maintenance. Hiring and retaining qualified health IT staff is another burden to bear due to challenging economic conditions and shrinking technology budgets. Healthcare executives have even bigger headaches when their organizations lack the expertise and resources to meet providers' data exchange needs. Doctors, too, are frustrated because of delays and difficulties in accessing patients' health records. They bear the burden of disparate EHRs, along with fractured and disconnected sources of health data. If only there were a way you could let someone else tackle your interoperability challenges. With Mirth Cloud Connect, you get the following services that help ensure optimal health data exchange. A team of experienced interoperability talent is ready to implement high-quality integrations, enabling you to take advantage of quicker development cycles. Deployed on the serverless AWS cloud, Mirth Cloud Connect was built with scalability, security, and regulatory compliance in mind. Experts are on standby, ready across all time zones, morning, day, and night to resolve any issues your interfaces may encounter. Lowering barriers to better interoperability shouldn't break the bank. NextGen Healthcare works with you to determine your investment as you scale your data exchange capabilities. Mirth Cloud Connect provides a fully managed service that alleviates the pressures of complex data integration. Your providers get the information they need to make the best informed decisions, and you get the peace of mind of having an ever-vigilant interoperability partner. That's better healthcare.
And now if you could, please take a few seconds to read the bios of our moderator and panelists.
Okay, great. Can you hear me okay, Carol? Okay,
Yeah,
looks
indeed.
like you can. Well, good afternoon to everybody. I've been listening to most of these really informative discussions today, and I've learned a lot. So thanks for the team that's put all this together. I'm Jim Tate, the moderator of this segment. I'm looking forward to this roundtable on the future state of interoperability. First, let me give our three participants a minute or two to introduce themselves. Lisa, would you step up and give us a little bit about your background, please?
It's always hard to find that mute button when you need it, right?
Yeah.
So thanks so much, Jim. As my name is Lisa Nelson. It's an honor to be here with the rest of my panelists. I'm a medical informaticist innovator. I've been in healthcare for over 25 years with a lot of experience in developing products that use standards and developing standards themselves. My background is in a little bit in the V2 space, but primarily in CDA and now more recently in the use of FHIR and of course Direct. I'm a contributing author on multiple national standards implementation guides, including Consolidated CDA, a big favorite, and some others you may not have heard about, Personal Advanced Care Plan, and a FHIR guide that's called Advanced Directive Interoperability. I've also worked with the DirectTrust guide on event notifications via Direct. I co-founded the CDA management group at HL7, and also a nonprofit that's called Family Health Data Network. So I have a lot of affinity with the ladies that spoke on the previous panel. It's an organization that fosters 21st century health literacy for consumers. In 2022 and 2023, I led the DirectTrust Directory Improvement Initiative. And this year, I joined a company called ADVault that I've been consulting for a while, but now I'm their Senior VP of Enterprise Integration. And this is really a focus on making it possible to share patients' goals, care experience preferences, and treatment intervention preferences through interoperable advanced directive type information. It's a pleasure to serve on the panel today. Thank you.
Well, great. Thank you, Lisa. Mo, let's hear a little bit from you, please, sir.
All right. Hello, everybody. Thank you so much for having me on this awesome panel. My name is Mohammed Chebli. I work at NextGen Healthcare, where I'm the VP of Solutions, responsible for interoperability and data exchange, really across our portfolio of capabilities, including many of our Mirth solutions, like our integration engine, our Mirth Connect open source integration engine, Health Data Hub, our data aggregation platform, Insights, our reporting and BI tool for HIEs. And also a big part of my work is also focused on core EHR interoperability. I'm lucky enough to sit on the board of DirectTrust. And of course, like the universal cliche in healthcare, you know, I'm also a patient, right? I had a ton of interactions in our healthcare system, as we all do. And I think I know a little bit firsthand the building side of what interop looks like on the provider space. What are the challenges that providers and organizations face in implementing interoperability? But also kind of as a super patient, what does the interop universe look like for patients who have interactions in our healthcare system and are subject to some of the interoperability challenges that providers go through? And patients, of course, we have our own challenges with interop and getting access to data. So I'm really excited about this panel and this entire day of content. You know, hats off to the organizers. It's been an action-packed session so far. Really happy to be here. Thank you, everybody.
Thanks for that, Mo. Justin?
Hey, everyone. I'm Justin Villines. I think I'm from Arkansas native. I grew up in rural America, right? So things that I talk about throughout this will kind of coincide probably with a lot of us, but I'm the Health Information Technology Policy Director at the Office of Health Information Technology. We are a division of the Arkansas Department of Health, and we oversee SHARE, which is the State Health Alliance for Records Exchange. We're the statewide health information exchange for Arkansas. So interoperability, I geek out a little bit and really think about data, think about making sure that we're getting the results to the providers when and where they need it. Prior to working at the HIE, I've been at the HIE since 2014. I had worked at the University of Arkansas for Medical Sciences in different positions, but all of those, I think, really set the groundwork for my work at the HIE, from outpatient, inpatient, quality, and then prior to that, I had federal service in the military. So I'm glad to be part of this panel, and I think we have some exciting things to talk about.
Well, great. Thank you for that, Justin. Let me kind of set the format here. There's a number of questions I'm going to ask. I'll ask those questions, and I'll give each one of the three of you an opportunity to react to those questions for a couple of minutes, and then we'll have a couple of minutes if you want to fill in some more information after you've heard the other folks talk. I want to get through all the questions that we have, so my job is to crack the whip a little bit today. So the first question really has to do, before we really think about the future of interoperability, it's wise to take a moment to look back at where we started and where we are now. What's your assessment of where interoperability is currently and where we're going? Lisa, I'm going to throw the ball to you first, please.
Oh boy, I guess it's ladies first every time here.
No,
We're
we're going to switch it up. Don't worry.
So, Jim, I wanted to reflect on this from sort of the patient point of view. My other panelists can cover some of the other ground, but I wanted to represent that aspect of things. And as I look back over the years, And remember back when meaningful use, Dee Dee Davis talked about how the policy and the regulations have changed over time. But when meaningful use was the driver and consolidated CDA was what we were aiming to do, what I recall was a knockdown, drag out fight to try and get a patient generated document included in that set of 10 documents. And the resistance to adopt the notion that patients could communicate and share their information running on the same rails, using the same standards as what was being built for clinicians and payers and registries and the rest of the stakeholders. And winning that fight was a step in the right direction. And we've come a long way. Regulation now and some of the ability to have patient right to access as a new driver, I think is driving new possibilities. But in the past, it was a big challenge. The regulatory environment seems to be changing. The recognition of social determinants of health as really an ultimate, if not a majority contributor to getting good health outcomes, which is all of our goals. All of those kinds of changes are helping us with that shift of focus onto realizing that the patients and the caregivers really are a driving force that we have to reckon with and that we need to be ready for. Unfortunately, in today's world, what I still see is patients coming last. I work now in my position as enterprise integration, bringing technology like advanced directive types of documents to be ported into EHRs. And the FHIR APIs that are available to do this kind of work are set up for documents that are authored by providers, not documents that are authored by patients. And figuring out how we're going to win that battle is like Groundhog Day for me. We're just going to have to do it over again. So I think we've come a long way, but I think that it's very easy still for patients to be forgotten off the bus. And it's something that we need to double down on for the future.
Okay. Thank you, Lisa. Mo, where are we at and where are we going?
Yeah, I think Lisa hit it right out of the park. I mean, let's remember where we started. EHRs did not speak literally the same language, right? That was the old saw. Providers, all of us in the industry were saying EHRs don't communicate well together. So hats off to HHS and ONC for establishing regulations that required a level playing field across the content universe, the transport universe, all the different mechanisms for how data should be exchanged. And of course, also requiring APIs, right? What Lisa talked about with FHIR APIs are now a regulatory requirement for all health tech that gets certified and that providers rely on for CMS, payment programs and other reasons. So let's not forget where we started, right? We had to, lay the copper. We had to establish these connections before we could build the scaffolding and the infrastructure that actually exchanges the data that we're talking about. So we don't often hear, at least not as frequently, that old cliche that, these EHR systems don't speak the same language, they don't talk to each other. We have a different nature of an issue now where there's almost a situation where there's interoperability overload. There are too many documents and data flowing, and now the providers have to spend time, cognitively reviewing and analyzing everything that gets exchanged. And from a provider, different specialty perspective, there's also the open question still today, right? Haven't seen this fully abate just yet, of whether or not providers are responsible for all this data that gets exchanged, through their system. If you're a cardiologist and you get notes for a different procedure, are you now responsible for following up on those other conditions? So there's still some regulatory hurdles, there's still some policy hurdles, but I think objective observers would say that we have far more interoperability today than we've ever had before. As an industry, I think we've done a lot of heavy lifting to the credit of all the organizations that participate and build those standards and then implement them. But hey, I think like everyone else, there's so much more that we can do to minimize the provider burden, to minimize the patient burden, and to try to really meet the full expectations that we all had when we were implementing EHRs, right? The expectation that the combined data from all these systems, right, will feed back to public health interventions and help us identify new treatment opportunities and new research opportunities. I still think a lot of that is in reach for us. And, you know, I'm looking forward to hearing about like Justin's thoughts on the future of interop, because this is going to, I hope, lead into the future of how we're going to use all this combined data in a better way, which is still, I don't want to say entirely eluding us, but I don't think we would all say that we have, you know, although we have more interop, that we've developed more insights from the data that's actually been shared. I still think we're very much in the early days of getting entire full use of this massive amount of content that's actually moving back and forth. We're doing a better job. We have a lot more to do.
I couldn't agree with you anymore. I think a lot of the plumbing is in place. Yep. Yeah. Justin, your thoughts on this same thing of where we are and where we're headed?
Yeah, we've come a long way, but kind of diving back, when I was working at the university and during residency programs, we were implementing an EMR, and there were so many different facets on it, you know, educating our providers, educating our residents, but everything was kind of not out of the box. You know, every electronic medical record system was certified, but you had kind of an a la carte. Let's pick from these, here's 20 items for under meaningful use, you select 3 or 4. But the problem of that is many certified systems selected different things that they wanted to go after. So then we have a nation of certified EMRs, but all of them have different capabilities, right? So we know that, you know, under meaningful use, it was a big push, some incentives that were given to health systems to kind of give where we are today, which is amazing. But there's still a lot of holes when we look at that interoperability from EMRs. And then coming from a health information exchange that's statewide in Arkansas, we know we're vendor agnostic, we're connecting to each one of them. But when we look at interoperability and we're connecting to each of those electronic health record systems, it's a little different in each piece, which is okay. But it also allows for us to not go through those standards. You know, we're kind of having to do a little more legwork where we would think that we should already be there in some instances. I think there's a great opportunity, especially with the qualified health networks, whatever that looks like, right? They aren't real, but where they are. I think with health information exchanges, especially after COVID, being able to assist with our public health reporting to our health departments, CDC, you know, NIH, kind of getting that information. The streets are there, like Mo and Lisa said, but we have to be able to optimize that, go through a standardization. And if we're able to do that, not just in one health system, not just in one state, but we have to do it from a national standpoint, because at the end of the day, we got to make sure that those results of that diabetic patient gets to that endocrinologist or the primary care physician when and where they need it. Because that data may mean the difference between a visit to the emergency room or having a readmission. So as we're embracing interoperability, as we're optimizing the use of health information exchange and EMRs, we're working with our payer partners to align and take provider and healthcare burden away. You know, it's all about value-based contracts. How do we get there? We have to follow metrics. We have to be able to use the data. So really optimizing and how we're inputting data within the EMRs and then pushing it to where it needs to go. That is going to be, it's the now, it's the future. And so we have to be able to work together as an ecosystem, not only from health systems or from one, but all together to accomplish this goal, because it's huge and it's ever going to get more complex. But we have to take it from a step back and remember, like Lisa and Mo said, and just that it's about the patient. We can have all these bells and whistles, but if we can't get the simple data to where it needs to go, are we truly having an interoperable system? And so that's kind of my 2 cents on that.
Great.
Yeah.
Yeah. Thank you, Justin. I'm going to break my own rule. I said that we'd, after everybody got to reflect on these questions and respond to them, we'd have time to kind of have a back and forth. If we have time at the end, we'll do that, but I want to stay on track. Mo, the next question, I'm going to start with you, and that is, what are you most excited about when you think about the future of interoperability?
I think, I don't know, maybe like everyone, hopefully I'm not the only one on the call thinking this, but I'm incredibly excited about the AI and large language model tools that are already available and new ones that are coming. And if you haven't already, I'll highly plug the book by Dr. Peter Lee, The AI Revolution in Medicine, is really kind of central to all the work that we're doing. And, as part of, just exploring that book and some of it really focuses on Chat GPT and GPT-4 use cases in healthcare IT. It asks a very direct question about the need for interoperability. If large language models can assist in summarizing clinical visits and understanding longitudinal records, what's the need for actual interoperability? So I'm entirely excited about AI and LLMs helping assist with some of the core challenges that we already have today in interoperability. Number one, summarizing lengthy notes that include tons of clinical information. Stacks of notes that you may have received for a brand new patient require a human being to sift through and identify the actual chronic and important conditions. So there's an essential need there to analyze data. And LLMs, I believe, can assist with that. There's also one thing that's really exciting, is a little bit more on the practical and tactical, is on server side filtering. So all of these large national networks today, Care Quality, eHealth Exchange, even things like the SureScripts record locator or your vendor's interoperability platform. There's a lot more that the platforms can do to filter and add kind of intelligence around the interoperability. So I know DirectTrust, for example, is working on things like, the provider directory improvements to make it more scalable, to make it more usable for organizations to find folks that they're looking for. There's a lot more that these large platforms can do to make interop capabilities, when they show up in the provider's office, more useful for the people who actually need to interact with them. So I'm very excited about the role that these large national networks can play to improve today's data sharing, right? Without having to wait for some big brand new technology.
Sure.
And then the last thing that I'd say I'm really excited about is voice integration at the setting of care, right? And so providers today are using natural language. There's tools that are being launched to do things like in-room audio, to capture notes and to record the entire interaction with the patient. And these AI tools can really help not just, create the orders, create the referrals, create the actual, HL7 transactions that are going to deliver the order request, receive the order result, et cetera. The voice integration that's happening at the bedside, so to speak, I think is going to have a lot to say about interop orders that are going to come as an output of that visit. So I think voice is going to play an important role in kind of maybe being an early start of an interop workflow. And that's something that's brand new for all of us, right? Doesn't really today exist in most EHRs, but I think is gonna be something we all have to think about and find creative solutions for. So AI, LLM, platform side improvements, and voice are the three things I'm most excited about right now.
Mo, what was the name of that book you mentioned?
The AI Revolution in Healthcare, by Dr. Peter Lee from Microsoft.
I can't wait to read that. Justin, let me throw it over to you. What excites you about future interoperability?
Yeah, I think everyone, it's a newer term that's being used, but we know what health information exchange is, right? We've been working on that for a while, or data exchange, but health data utility, utilizing the streets that we already have created, whether it be us using DirectTrust secure messaging to notify our providers when an ED or inpatient happens, or taking clinical data from one health system and delivering the results to primary care. But I think it's much more than that, especially after the pandemic, where we need to utilize and focus a lot on assisting, our foster care kids on, working with DHS to utilize our infrastructure that's already together and utilizing as a health data utility, HDU, to be able to notify pediatricians when a kiddo gets taken into foster care, assisting our health departments around the nation on doing public health reporting in a streamlined manner. Being able to work with our traumatic brain injury registries or our providers and notifying them when events happen for that person with TBI. So utilizing our infrastructure as a utility, being able to provide the services to our communities, both urban and rural. But I always go back to rural because I look at my grandparents that live in rural Arkansas, and where it's 50 minutes to the nearest hospital, but they go to the local clinic. They need to be able to talk to each other, but we need to be able not just to share the clinical results, but also show that maybe just what happened, but that clearer picture, that holistic view of what's going on from one EMR to the next. And we have the structure there, but really focusing on, utilizing that as a utility, but not forgetting that it's not just, hey, let's turn something on. We have all of these bells and whistles with an EHR. We have capability with health information exchange, or we have patient access. But workflow is so critical, because if our providers and our health systems or even our IT do not understand all the ins and outs, then all of the great things that we're putting in place just won't work. It won't all flow together. So I'm a real firm believer in workflow and working with boots on ground individuals, so that we can be able to educate them, all of the one that's touching the patient, that they know, from A to Z, and then utilizing the utilities to be able to push that information accordingly.
Right. Thank you, Justin. Well, Lisa, when you look in your crystal ball and look in the future of interoperability, what excites you there? Yeah. Anything exciting that might be
Right.
over the horizon?
Well, I'll try. I'm excited about a lot of stuff. I'm going to focus on 3 just on account of the time.
Okay.
So the first is that I've actually heard that the first use case right after treatment, payment, and operation is going to be patient right to access.
Mhm.
And the reason I'm excited about that is when you consider all the cool technological stuff that Mohammed talked about and some of the things that Justin mentioned, what I worry about is, how do we know what's right, what's accurate, after the data has gone through all this cool transformation and resolution and brought to standards and fixed up for quality and all that? How do we know that what comes out the other side for doctors to consume is actually right? And I think that by engaging the patients, it's the best chance we have of getting that confirmation that the quality of the information is valid. So I'm really excited about patient right to access being an acknowledged national initiative that will come next. I'm pretty excited about the AI aspects of things, because I think in our efforts to achieve interoperability, we got so fixated with structured data that we forgot human language and ultimately people communicating with people. That's one of our number one use cases. And so when we can get the data back to being language oriented and summarized in the way that our human brains can understand it, I think that's going to be a very powerful swinging of the pendulum back in a better direction. And finally, I'm really excited about the data elements in US CDI v4 driving us to have to embrace not just patient goals, which have been there all along, but now care experience preferences and treatment intervention preferences. Because as we look into the, crystal balls are tough, but one thing I can tell you for sure is population and what we know is going to be happening about the population is one of the clearest aspects of a crystal ball. And the aging of our population over the next 3 decades, the number of elderly people that we are going to have and need to take care of, maybe even in their homes, if things go the way that we perceive they'll need to. More caregivers, not the patient themselves, but the designated daughters and the selected sons who are trying to take care of their children, work full-time jobs, and absorb the care of their beloved parents. This is going to be a game changer. And I really think that that being able to communicate and force our systems to have two-way interoperability, where information from the patients can come into the system about these kinds of data elements like care experience preferences and treatment preferences, it's going to be the driving force of a big game changer in interoperability, which is that it's a two-way street, not a one-way path out. That's the spigot we have today. Data can get out, but no data can really get in. So I think that's going to be a big game changer.
I think we have one more question that we can hopefully flesh out to some degree. And Justin, I'm going to go to you first. It's your time to be first.
Yay.
And this is really, this is something that I always wonder about. You know, we can put in all the plumbing, but who's going to actually figure out how to make things flow? And so what can people and organizations do to get on board and make some of these future states that we've been talking about actually happen?
Yeah, one thing that we're still very health systems and organizations, they're still faxing medical records, right? And I think it's not just a little bit, it's still a lot. It's the old way that we're doing things, right? We have to be able to stop that. It's not secure. It has so many security concerns. So, in able to do that, I'm going to piggy what Lisa said, not just from the patient perspective, having the bidirectional capability, but our EMR systems. They must be able to not only document stuff on document clinical results, but they must be able to query or bring in outside records from any EMR in order to empower our providers. If we, our nation is moving with accountable care organizations, they're setting up clinically integrated networks, they're working with payers with value-based contracts and part of programs. The driving force of that is data. We have to know what our patient population is looking like. And on average, the literature states that a healthier patient goes around and sees 18 different providers. Think that that's a healthier. A person with comorbidities are going to see 25, 30 different providers, and not all of them are going to be in the same health system with the same EMR. So we have to be able to have that bidirectional capability from our EMR systems and utilizing the health information exchange to be that conduit that connects all those EMRs, but then allowing those health systems or clinics, et cetera, to be able to bring that information in. Lastly, I think social determinants of health is so important because we can know what clinically is going on with the patient, but if we don't understand the clear picture of the unhoused or a person that has food insecurity, and then that's part of the patient's chart, I think we're missing some key elements. We know it's a buzzword, but it's a buzzword for a reason because we know that people are unhoused at high levels nationally. The healthy food on the table is even becoming harder because of inflation. But if we can be able to empower and bring that data into the EMR, push it out or make the health information exchange as that utility to be able to make it available to everyone that has a treatment, payment, or operational need, then that's a win-win, not only for your community, your state, but the nation as a whole.
Great. Thank you, Justin. So, Lisa, what can people and organizations do to get us from where we are now to where we think we want to go in terms of interoperability?
Well, I had kind of a practical thought on this. I knew Justin was going to be on the panel, and I wanted to talk a little bit about the role of HIEs healthcare all happens locally. The majority of what's going on with any one of us or our family, it's happening in the context of our town, of our state. And I remember when the RCE money was available under meaningful use, and I was thinking, wow, the HIEs are going to start running campaigns. We need consumers to understand and to learn the language and to have the consumer expectations and knowledge and capabilities brought up at the same time as doctors. Well, I don't know if there wasn't enough money to do it, or again, the priority is always to get to the doctors first, connect the hospitals, do what was needed there. But I would love to see the efforts roll to our HIEs and have our HIEs as data utilities and really educational utilities to help us connect out into the people in each of our states. We all know rules are a little bit different from one state to another. And this seems like a perfect avenue to be able to not only have data flow, but to have the education, the language. When somebody says, did you get your discharge summary after you've been in the hospital? I would love it if everybody understood that statement in the same exact way, that we know what a discharge summary is, we know when we're supposed to get one, and we know what information is supposed to be in it, so that hospitals, HIEs, consumers can all get on the same page. I think that's just what's going to help accelerate the benefit that we're going to get from all this investment in health IT.
Lisa, there's what I've got to throw in my 2 cents here, because you mentioned the RECs, the regional extension centers. The massive amount of federal money that went to helping providers acquire EHRs, and then through the RECs, the training of using of those. I'm not aware of any substantial funding for the training of the interoperability process. Maybe there is, but I'm not aware of it. Mo, let me throw it over to you. So what can people and organizations do to help keep the ball rolling towards what we hope is going to be the future of interoperability?
Well, I think it's like Lisa and Justin have both shared. There's a ton that organizations can do today without waiting for some fanciful, as yet not delivered future. There's a lot of interop that's happening now that if your organization doesn't have that experience, I think there are 3 things they should be thinking about and doing right now. Certainly for healthcare delivery organizations, hospitals, health systems, your vendor, almost any vendor at this point, has some minimal level of national interoperability, right? They are a HISP or they're connected. You've got direct messaging. They're connected also to the national networks, Care Quality, eHealth Exchange, Commonwealth. All 3 of those have robust and meaningful levels of exchange with practically everyone else. So you don't have to also just wait for a QHIN to get turned on in order to get the benefit of interop right now. And I'd say connecting to a local HIE. So number 1, talk to your vendor, figure out what the services are with your vendor. Number 2, connect to a local or regional HIE in your neck of the woods. There's literally no other organization, to piggyback on what Lisa was saying, that has a pro-competitive goal of connecting everyone in their geography for secure, robust data exchange. And importantly, the HIEs are not just doing document shipping from point A to point B or clinical record exchange. They're also going much further with things like quality management for organizations, quality reporting, social service connections, right? All that SDOH story that we've been talking about in our industry for a while now. If you look closely, the HIEs are at the forefront of connecting all those social service agencies in their neck of the woods. And I'd say maybe the last thing, there's been a lot of talk over the many years of kind of shifting to the cloud and doing a lot more functionality in the cloud. And so more vendors today are offering cloud native interoperability solutions. So Jim, to your question about there being no robust or universal training for interop, let's not forget that the 21st Century Cures definition says interop should happen without special effort from organizations, right? It should just work. And so if that's what we're shooting for, cloud deployed services that are managed on your behalf, that don't require a lot of, care and feeding. We've gone through a pivot in healthcare where we've shifted a lot more to the cloud, as other industries have. And I think a big part of that is also available for interoperability. There are now managed cloud services that handle your data exchange on your behalf, so you don't have to. And so I highly encourage organizations to check out cloud native solutions that can do that heavy lifting, either pivoting your existing integration to the cloud or literally just using the integration capabilities from your cloud provider. Often your EHR vendor has something comparable. So I think there those three things. Your EHR vendor has a ton of capabilities. Your local HIE absolutely should be turned on and connected, and then look for opportunities to shift as much as possible to the cloud to reduce the load on your organization having to manage the day-to-day of these integrations. So I think those are three things that don't require waiting for perfect in some future, world of interop, but can all be done and highly encouraged right now.
We're almost out of time, but since I am the moderator, I get to have the last word, they tell me. It seems like for the last 7 or 8 years, every year is the year of interoperability. And so I don't think that interoperability is really a destination, it's a process. So what is defined as end goal of interoperability is going to change over time. There's going to be new types of data that need to be collected, genomics, new standards, US CDI, all those things, regulation standards are going to continue to change. And the ability for an increased level of interoperability, and Justin, kind of what you talked about a lot, is the actual workflows of how this data is handled for the best outcome. I don't think we're going to get, in my opinion, to the end of the rainbow, but we are well on our way over the arc of the rainbow. I'd like to thank our panel today for providing their insights on the future state of interoperability. And to our audience, thanks for joining us today. Carol, I'm going to hand things back to you.